Oh, great. So I picked the topic of cystatin C because genuinely I am kind of interested about this and I want to learn more about it. And the best way to learn about something is that you have to do a presentation. So you kind of force yourself to read a lot about it. So I never heard of cystatin C when I was a fellow and I actually never used it. I think I started using cystatin C in my clinical practice probably starting in 2019. I've been ordering on some of my patients and then more frequently lately. For those of you who don't know me, my name is Chen. I'm a clinician primarily based off at the University Hospital. So the topic for today is cystatin C. This is a new and improved way to evaluate renal function. So before I talk about cystatin C, I kind of want to talk about creatinine. What are some of the limitations to use as a biomarker to estimate GFR. So creatinine is formed, it's an end product of creatine and creatine phosphate metabolism. And the creatine is primarily formed at the liver and the kidney, and the little part of it's made in the pancreas. Then it is transported to the heart and skeletal muscles. And then it undergoes non-enzymatic anhydration, it becomes creatinine. It's a low molecular weight molecule. It's about 113 Dalton in size. It is filtered at the glomerulus and also secreted by the proximal tubules. So medication that inhibit tubular secretion can also affect the serum creatinine level. And this medication includes trimethoprim, dronabinol, probenecid, salicylate, cimetidine, some of the antiviral medication we use for HIV patients, and some of the chemotherapy agents for cancer patients. And the serum creatinine, because it's primarily stored in the skeletal muscle, it is really affected by age, gender, muscle mass, and liver function, and also the diet. Creatine is found in dietary protein, and then it gets converted to creatinine with heat. So people who are on a diet with high consumption of specific red meat, cooked red meat, they have a higher level of serum creatinine. So let's look at cystatin C. It is a small non-glycosylated protein, about 13 kilodalton, and that's encoded in a housekeeping gene. It is produced by all the nucleated cells at a constant rate. It is freely filtered through the glomerulus and then 100% reabsorbed and catabolized by the proximal tubular cells. It is not secreted by the tubules, and it's also not affected by age, sex, race, muscle mass, or dietary intake. And then just in comparison, in terms of size, it's actually very similar to beta-2 microglobulin, which is about 12 kilodalton. Excuse me. And then production is, I'm sorry?
Annie, it's Isaac, I'm sorry. But you're right on a slide that's something that's always puzzled me. That not affected by muscle mass. It's produced by nucleated cells. So if someone is a double amputee and has lost a lot of cells, how could not be affected?
That's a that's a very good question because it is produced by all nucleated cells. I don't know. But the other thing I thought that was interesting is, for some reason, production of cystatin C actually stabilized after the age of 1. So if you look at like cystatin C level for kid that's 1 year old versus adults that's 49 years old, the level is actually the same. So it's a good question. I don't know.
Okay. All right. Thanks. Sorry.
No, I think that's a really good question. Because muscle cells are nucleated cells, so you should have higher production for people who have more muscles. And this is, then I kind of want to look at cystatin C used in different sort of clinical contexts, right? So cystatin C changes more rapidly compared to creatinine in the setting of acute kidney injury. Creatinine equilibrates in total body water, whereas cystatin C is restricted only to the extracellular space. And due to this difference in volume distributions, cystatin C changes more rapidly compared to creatinine in the setting of acute kidney injury. meaning cystatin C level will rise earlier than the creatinine at onset of AKI, but it also decreases sooner than creatinine with renal recovery. So this is a German study done by Hagar Rosenthal, and they look at 85 ICU patients at a University Essen who have normal eGFR identified to be at a high risk for developing AKI, and then measure the serum creatinine and cystatin C every day. And then AKI is detected according to the first three rifle criteria. R is for serum creatinine increased by equal or more than 50% from the baseline. And of these 85 patients, 44 of them actually developed AKI during the hospital course based on the R criteria. And then the other 41 patients, they used them as a control group. And this is a graph. So our dash day 0 is the day that AKI is detected based on serum creatinine using the R criteria, meaning the creatinine has increased by equal or more than 50% compared to the baseline. And this is a European study. I'm not used to this creatinine because it is the unit is micromole per liter. So I calculated it and they changed them to units that I understand. So you can see that for those people with acute kidney injury based on the serum creatinine level, the level of cystatin C actually started to increase by day 2. So 2 days prior to the serum creatinine actually picked up the acute kidney injury. The cutoff of normal cystatin C they used was 1.10. And you can see by day 2, it's already a little bit above normal and it increases more rapidly than serum creatinine. And of the 44 patients, the cystatin C level and the creatinine level remain fairly normal at the same time period. And then what about patients in the ICU, right? So a lot of ICU patients are immobilized because they're intubated, they're paralyzed. So the muscle mass actually decrease during the ICU stay, especially if it's prolonged. So using serum creatinine, because it is based off on muscle mass, it may not be the most accurate way to detect acute kidney injuries in these patients. So this is a study. Sorry, I was ahead of myself. This is a study that looked at cystatin C concentration as a marker for acute kidney injury in critically ill patients. It's published in Journal of Critical Care in 2005 by Bilal et al. So basically they measured the serum creatinine level, cystatin C, and 24-hour urine creatinine clearance in 50 critically ill ICU patients. And about half of these patients had renal dysfunction, which they defined by the 24-hour urine creatinine clearance less than 80 ml per minute per 1.73 meters squared. And then when they look at these patients' cystatin C versus serum creatinine level, they saw that only 20% of the patient had an elevated serum creatinine at the time of renal dysfunction that's defined by the urinary creatinine clearance, whereas more than 3/4 of the patient had an elevated cystatin C at the time of renal dysfunction detection. So another way, this study suggests that using cystatin C, it may be a more sensitive marker to detect acute kidney injury in critically ill ICU patients. This figure is a ROC plot that compared the sensitivity and the specificity of serum creatinine and cystatin C in detecting the renal dysfunction. And then when it's compared with what they think is a gold standard, the 24-hour urinary creatinine clearance. And then for those people who's not very familiar with the statistics, I had to actually look at sort of the meaning of the ROC plot. But basically, it is like a way to compare or determine the diagnostic accuracy of certain tests. And this 45-degree diagonal line shows that diagnostic tests it's as good as if you just subject it to random chance. So the area under the curve for this line would be 0.5. And then if a curve that goes the curve that goes this way, then the area under the curve will be 1, and that's typically the gold standard. So the higher the test that's this way, the more accurate it would be. So in general, the higher the area under the curve means the more accurate a diagnostic test is. So this is the plot for serum creatinine, and the area under the curve for serum creatinine is about 0.69, whereas the area under the curve for cystatin C is 0.93. So based on this finding, the author of the study conclude that the cystatin C, it is a better marker to detect renal dysfunction in critically ill, unstable ICU patients. Okay, so why is estimation of GFR important? Like why is it important that we should be able to accurately assess it? Like what cares, right? So this plot, I got this from the 2010 KDIGO Controversy Conference and report published in Kidney International in 2011. It is showing that patients with lower estimated GFR, especially those less than 60, it is associated with increased all-cause mortality, cardiovascular mortality, higher rate of progression to ESRD, more likely to develop AKI, and also more likely to progress to chronic kidney disease. And then the other thing that also shows is the degree of albuminuria also have association. So the black line is when there's no albuminuria, green is when it's 30 to 299, and red it's greater or equal to 300 milligram per gram. And then you can see like the more the albuminuria, the higher the risk for all these categories. But in bottom line is because estimated GFR does have the implication in terms of mortality and progression of disease, it is important that we should find a way to really accurately assess it. So in the last few years, there has been a push to exclude race in equations such as EGF calculation, because race is really a social but not really a biological construct, and it's also a self-reported variables. In fact, like at the University Hospital, we have dropped the race reporting for EGFR, so now that there's only one EGFR with the serum creatinine calculation. That's reported in our EMR system. So the author of this study, they want to examine the accuracy of different EGFR equation using different biomarkers, creatinine versus cystatin C versus a combination of both in Black and non-Black patients. This is a study done by Inker et al. That's published in New England Journal of Medicine in November of last year. So they use the same data set previously used to develop the equation for CKD-EPI, and which includes 10 studies that have serum creatinine and 13 studies that have cystatin C. And then for validation, they also have another 12 study, which includes more than 4,000 participants, and about 14% of them are Black. They compare the accuracy of the new EGFR equation that they developed to measure the EGFR in its patients. And then what they found, so this table actually does not exist in the paper, but I made this table to simplify the study and also for better visualization. So the different columns are the different EGFR equation, current versus new, and also whether or not they use a combination creatinine cystatin C or just creatinine or cystatin C. And then the rows are the different patient group, Black versus non-Black. The top part of the table, they look at the bias of the different equations. And what they found is the current EGFR equation using creatinine alone tend to overestimate GFR in Black patients with minimum bias in non-Black patients. And then when they use a new EGFR equation using creatinine only, they actually found the opposite and underestimate GFR in the Black patients and then overestimate eGFR in non-Black patients. And then you can see really the bias is actually really minimal when the eGFR using cystatin only. And the bias is also minimal in Black patients with the new eGFR creatinine cystatin in the calculations. And then the bottom part of the table, it looks at the P30 for each of the equations. The P30 really refers to the percentage of patients, the eGFR, which are within the 30% of the measured GFR. And then you can see that the bias is minimal in Black and non-Black patient when it's when they use their new eGFR equation, use a combination of creatinine and cystatin in their calculation. That in this group, the P30 is greater than 90% for both groups. So based on this, the author conclude that the new eGFR equation incorporating both the creatinine and the cystatin are more accurate than the new equation that use either creatinine or cystatin alone. Then I want to kind of look at, well, what about cystatin can we use in risk stratification, right? Remember a few slides before I said eGFR does have implication in terms of determining the risk for mortality and the progression of AKI or CKD. So this is a study that's published in New England Journal of Medicine 2013 by Shilopak and his group. They look at cystatin versus creatinine, determining the risk based on kidney function in both the general population and those with chronic kidney disease. So it's a meta-analysis of 11 general population cohort studies and 5 CKD cohort studies. They have more than 90,000 participants in whom the creatinine cystatin were available. Then they compared the association with eGFR with the rate of death from cardiovascular cause, and then also progression to ESRD. And then assess the impact of reclassification of eGFR when they use of cystatin. So basically, they use the cystatin and then certain patients are reclassified to different eGFR group, and then look at whether or not the reclassification of eGFR based on cystatin, if that has any association in terms of predicting the rate of death from all cause, from cardiovascular and progression to ESRD, if that has any impact. So what I found is when cystatin is used, those patients who were reclassified to a lower eGFR group, they tend to have a higher risk of death from all cause. And then when patients are reclassified to a higher eGFR group based on the cystatin, those patients tend to have a lower risk of death from all cause. And this is the forest plots they use to see whether or not cystatin is a better prediction marker for all-cause mortality, cardiovascular mortality, and the progression to ESRD. And it shows that in the general population, cystatin seems to do better than serum creatinine as a prediction marker for all 3 categories. And then for the patient who have underlying CKD, it's also a better prediction marker than serum creatinine in terms of when you look at all-cause mortality and cardiovascular mortality. And based on this finding, the author conclude that the use of cystatin alone or in combination with creatinine can strengthen the association between eGFR and the risk of death and ESRD across the diverse population, even in those who do not have underlying chronic kidney disease. So in 2019, KDIGO had a controversy conference entitled Early Identification and Intervention in CKD. And it was a strong agreement by the conference attending that eGFR should be estimated use both the creatinine and cystatin in parallel. This will lead to more accurate diagnosis and the staging of CKD and also cause less misclassification. than compared to just use serum creatinine alone. And the Cystatin also has an additional advantage of offering GFR estimate that do not require incorporation of a raised coefficient. Because if you look at a CKD epi cystatin C equation, really only includes age, the cystatin C level, and the gender. So this table shows the summary of the recommendations, and you can see point 5 and 6, it says accurate GFR estimate includes both the creatinine and cystatin C measurement for initial diagnosis and staging. And they recommend a combination of using serum creatinine, cystatin C, and the urinary albumin creatinine ratio to screen for CKD at the initial setting. And this really kind of gave me a pause because so far, I do check cystatin in some of my patients when I think, oh, serum creatinine may not be the best marker, but certainly I have not been doing for all my patients. The other thing is we did change our lab protocol for our new CKD patients about 2 months ago, and now that everyone will get a cystatin C check in addition to the renal function panel and then the other labs that we check for CKD patients. Okay, so the next thing I want to kind of talk about is drug dosing, right? So about 2/3 of the medication are primarily eliminated by the kidneys. And the more than 20% of medication used in the inpatient setting can be potentially nephrotoxic. And about 1/4 of the AKI cases occurred during hospitalization are related to medication toxicity. So accurate assessment of eGFR is important in guiding the choices and dosing of medication. Also, certain medicines are contraindicated below a certain cutoff for GFR, like metformin, linezolid, SGLT2 inhibitors. So it is very important that we find an accurate way to determine the GFR because it does change our decision in terms of medication use. So a lot of hospitals are still using the estimated creatinine clearance based off on the Cockcroft equation to calculate medication dosing hospitalized patient, including our hospital. I think the pharmacist is still using the Cockcroft equation to determine medication dosing. But this equation was developed in 1976 based on a cohort of 249 Caucasian males, during which serum creatinine was regressed along with other variables to predict and measure urinary creatinine clearance. This equation was developed actually prior to standardization of the serum creatinine acid, which did not come until early 2000s. That is to say, basically almost more than 40 years later, we're still using this equation that was developed in the 1970s to calculate medication dosing. And maybe it is time that we should look into that, whether or not this is still appropriate for given what knowledge we have now. So this is a study that's done by Peters et al. That's published in Pharmacotherapy in 2018. They look at whether or not cystatin C or like eGFR using the CKD epi equation, using creatinine, cystatin C, or combined, and how do they compare with the estimated creatinine clearance using the Cockcroft equation, which is the equation they do use in their hospital. So look at 308 patients with either suspected or documented infection and a stable kidney function who were hospitalized between the year of 2012 to 2015, and then they're receiving antibiotic agents. And then they estimate GFR using the CKD epi equations, using the creatinine cystatin C combined, and they compare that with the estimated creatinine clearance. We use the Cockcroft equation. And you can see, depending on which biomarker was used, the agreement between the creatinine clearance and the eGFR using CKD epi equation, it ranges anywhere between like 49 to 77%. And then if you base off the eGFR using the CKD epi equations, this group of patients, anywhere between 8 to 12% of patients will actually receive a higher dose. And then this group of patients, anywhere between 12 to 38% will actually get a lower dose of medications. So it is quite different depending on if you use a Cockcroft equation or you use a CKD-EPI equation when you calculate the estimated GFR. Well, and I looked through like a lot of studies when I was preparing for this talk. There's a lot of studies out there that are looking at, how does cystatin C compare with what we have in terms of medication dosing. And the most common medication that was studied was vancomycin, probably because it is used for a lot of infections, and also you can check a trough level to really determine the accurate dosing of medication. So this is a study that's published in Critical Care in 2014 by Frazee et al. It's a prospective cohort study with 173 hotspot patients at the Mayo Clinic in Rochester who's receiving IV vancomycin between March to October 2012. And the vancomycin dosing is based off the patient's weight, creatinine clearance using a Cockcroft equation, and then their clinical judgment. And the target vancomycin trough is either 10 to 15 or 15 to 20, depending on the severity of the infections. For those patients who have osteomyelitis, endocarditis, or bacteremia, they use a goal trough of 15 to 20. And it excluded a patient who have AKI at the baseline before starting vancomycin or prior to vancomycin level that was drawn. They drawn the vancomycin level just prior to the 4th dose. And they also measured cystatin C from the stored serum collected prior to the 1st dose of vancomycin. And then vancomycin trough prediction model was developed based on different equations to evaluate eGFR. And then they look at is the proportion of patients who would have achieved the target vancomycin trough level based on this each different prediction model using different eGFR equation. And I compare that to what they actually observe in their patient population. So in this cohort, only 20% of the patients actually achieve a serum vancomycin trough level within the target range under the usual care, which really is not that great. And then this table shows that, their prediction model is how many patients would achieve a target trough vancomycin depending on which equation they use to decide or to guide the vancomycin dosing. And you can see is with the eGFR CKD-EPI using both the creatinine and cystatin C, it has the best prediction model or the most patient that would have reached a target trough vancomycin level. More than half of them will achieve it. So the same group, they also implemented what they found in the prior study, and they did a QI project at the Mayo Clinic and published it in AJKD in 2017. So this is a prospective quality improvement project that evaluate med-surg ICU patient on IV vancomycin using 2 different dosing strategies. So between January 2012 to October 2013, patient were in their control group. This is what they used to do, is they use vancomycin dosing algorithm based on a creatinine clearance that was calculated by a Cockcroft equation. And then from December 2013 to May of 2015, they changed the vancomycin dosing algorithm based on the eGFR CKD-EPI equation, use both the creatinine and cystatin C combined. And then what I measure is how many patients have achieved the target vancomycin trough level using either the Cockcroft equation or a CKD-EPI equation. And then what I found is when they use the Cockcroft equation, only 28% of patients in this control group achieve a goal target vancomycin trough level versus 50% of the patients in the intervention group, the ones that using CKD-EPI to calculate their eGFR, almost twice as much patients actually achieve a target vancomycin level using this algorithm. So Let's look at cystatin C in elderly patients. So as we age, we do lose muscle mass. And as I alluded earlier, serum creatinine, it is affected by muscle mass of the patient. And so because and it is also affected by nutritional status, so EGFR equation using creatinine may not be the most accurate way to evaluate the renal function in elderly patients, especially in those patients who are frail and malnourished. So this study that was published in Annals of Clinical Biochemistry in 2003, they look at elderly patient in ambulatory setting with both the serum creatinine and the cystatin C measure and see how, which one's a better biomarker in picking renal dysfunction in this elderly patient. So they have a total of 52 patients, and the average age of this patient is actually 80 years old. And then they use the creatinine EDTA as the gold standard method to measure the GFR. And then they compare different ways to sort of estimate GFR. The calculated clearance is based off of the Cobb-Graph equation, and the serum cystatin C, serum creatinine, and then creatinine clearance. This is a 24-hour urinary creatinine clearance. And then they define renal dysfunction in this patient as less than 80 milliliter per minute per 1.73 meters square of measured GFR. So out of the 52 patients, 49 of this patient actually have a GFR less than 80. 38 have less than 60 and 26 less than 50. And you can see is if you compare cystatin C and the creatinine, cystatin C is a lot more sensitive than creatinine picking up this patient. So almost all of the patients, if you have an abnormal serum cystatin C when the GFR is less than 60, but only less than half of the patient would be picked up if you use serum creatinine alone. And if you look at a patient whose GFR is less than 50, serum cystatin C was able to detect all 26 of them who have renal dysfunction based on the measured GFR, versus serum creatinine only pick at half of this patient. So compared to serum creatinine, the serum cystatin C perform much better in detecting renal dysfunction in elderly patients with eGFR less than 60 and less than 50. So perhaps this is a more sensitive screening test to detect mild renal dysfunction in our elderly patient populations. And this is another study done by Potak et al. That was published in AJKD in 2020. It's a cohort analysis of over 9,000 participants that was in a sprint who had baseline measurements of serum creatinine and cystatin C. And then they want to look at what would be the impact of a eGFR difference when it's calculated based on cystatin C or creatinine. So they calculate eGFR based on CKD-EPI equation, and they look at an eGFR diff, which is defined by eGFR cystatin C minus eGFR creatinine. So eGFR calculated using cystatin C alone versus the eGFR calculated based on creatinine alone. So positive eGFR diff means the cystatin C based eGFR is higher than the creatinine based eGFR. A negative eGFR diff means the cystatin C based eGFR is less than the creatinine based eGFR. And then they look at certain outcomes like the frailty, instance of fall, hospitalization, cardiovascular events, and mortality. So what they found is about 71% of this, a little over 70% of their patients in this cohort have a congruent eGFR that's calculated either based off on cystatin C or creatinine. And about 14% of this patient, the eGFR based off on cystatin C calculation was much less than the eGFR based off on the creatinine calculation. And these patients all have a higher risk of frailty, falls, and cardiovascular events. And another 15% of this patient, the eGFR calculated based on cystatin C was much higher than the eGFR calculated based on creatinine. And all these patients have a lower risk of frailty, falls, cardiovascular events, and mortality. So it seems to me like when I'm reading this is cystatin C seems to have a better sort of predictor of predicting if patients are frail or have a higher risk of mortality. Because serum creatinine is depending on muscle mass, right? So patients who falls into this group who have a GFR that actually falls much lower if you use cystatin C in the calculation, they probably have less muscle mass, which I am not surprised that they are at higher risk for frailty or falls and maybe have more cardiovascular events in these patients. Oh, as I said, like creatinine is the end product of creatine, and the creatinine was partly produced in the liver. So patients with cirrhosis tend to have a low serum creatinine. And serum creatinine probably is not a very good marker to estimate GFR in these patients, but accurate assessment of kidney function in cirrhosis patient is very important, both for prognosis and also decision regarding dual organ transplantation. So this is a study that's published in Liver Transplant in 2021, that it's a meta-analysis to evaluate the performance of creatinine-based versus a cystatin C-based eGFR equation and compare that with a measured GFR in patients with cirrhosis. They look at total of 25 study with more than 4,500 participants total. And then what they found is all of the creatinine-based eGFR equation tend to overestimate GFR in cirrhotic patients, whereas all the cystatin C-based eGFR equation tend to underestimate GFR in the cirrhotic patients. And then when they look at equation using both the creatinine and cystatin C in their calculation, it tends to be least biased. So they do recommend, based off on this finding, is when you look at patient with cirrhosis, it is best to use equation that includes both the creatinine and cystatin C to estimate GFR in this patient for more accurate assessment. And next, I kind of want to talk about the evolution of cystatin C acid. So cystatin C was actually first discovered in 1979. The first acid cystatin C that was developed in 1979. It was a very complicated procedure that took about 2 days to actually complete, and then it's discovered and developed by Dr. Grubb. So then it took 15 years to actually automate the measure of cystatin C, and that was in 1994. Right now, there are 2 immunoassays that we use commercially to measure cystatin C. It could be the PETIA and the PANIA. And the first cystatin C assay that was FDA approved was actually not until 2001. And then initially, the cystatin C assay would run on specialized immunoassay instruments, which means it's really only available in really large labs or reference labs. In the recent years, manufacturers have made cystatin C available on the traditional clinical chemistry instrumentation, and this allows increased availability for cystatin C assays to run in small and large labs because they can use the same instruments to run their routine labs such as BMP and CMP. So there are 5 major clinical chemistry instrument manufacturers that represent majority of the market share in chemistry instruments in the US. And 2 of these 5 companies actually make their own FDA-approved cystatin C assays. So that is one barrier in terms of availability. But the other thing is there's only 2 diagnostic companies that manufacture reagent for FDA-approved cystatin C assay. So because of all this, compared to serum creatinine, cystatin C assay is really not as widely available. And then the turnaround time is much longer. So at the VA, I talked to Charles, who works at the VA. He says cystatin C is run in-house, and then usually the result comes back within about 24 hours. At Denver Health, they do the test in-house, but the turnaround time is about 2 to 3 days. And at UC Health, right now, we still send out the labs to ARUP, and it usually takes about 2 to 3 days to come back.
Hey, Annie, it's Sophie.
Yes.
At the VA, we actually get it back the same amount of time that we get creatinine.
That's amazing.
So
yeah. So Charles did tell me it's within 24 hours. I didn't know it takes same amount of time. That's great. Yeah.
Yep.
It's definitely not the case at the university. So I was going to say it's because of this turnaround time. So personally, I really use it in the inpatient setting, even though I do know that the cystatin C level rises and falls faster in the setting of AKI onset and also renal recovery. But because it takes too long to come back, I haven't found that very clinically useful for me in the inpatient setting, because I'll check a creatinine and then like 2 or 3 days later, I get a cystatin C level come back, but it's not as clinically relevant. At least for me, I don't know. So Sophie, do you find yourself check cystatin C more often at the VA because it has a faster turnaround time?
Yeah, we use it all the time, and actually house staff is now using it without our direction. Our spinal unit, they are using it instead of creatinine, or they do both. And then now in our clinic, we're doing for all new and follow-up patients, we're doing cystatin C and creatinine for all patients. So we do it acutely as well as in our chronic patients.
Got it. And you do that for, and so you use it both in the outpatient and also in the inpatient settings, right? So what you're saying?
Correct.
Okay. Yeah. I feel like the turnaround time, even if it's within the same day, I would have probably used it a lot more often in the inpatient setting. I don't know if any of the university attendings do things differently or if they do it more frequently in the inpatient setting. I do use it a lot more in my outpatient clinic. Yeah. Sarah, were you gonna say something?
Yeah, Annie, I would say, I was at the U 2 weekends ago, and we had a pretty profoundly uremic patient that ended up going on dialysis with a creatinine of something like 1.2, and we weren't able to get the cystatin C back very quickly. Took 3 days, and we didn't realize how uremic they were until we got that back, but we did a 24-hour urine. And in fact, there were 2 patients that their estimated GFR based on creatinine was, creatinine just wasn't reflecting. So I think for the university ICU patients, especially since they stay in house so long, some of them that we're really not capturing kidney function the way we should. And this patient had been on both vancomycin and cefepime and had a vanc trough of like 33, and a lot of things that were hard to figure out that would have been easily explained if we had the cystatin C sooner.
Yeah.
The patient that Sarah's talking about, we started CRT with a creatinine of about 1.4, something like that. And she woke up completely within 2 days. She was awake and 100% better, only due to the dialysis. It was incredible. And we have another patient in the ICU who's similar, whose creatinine is like 1.6 and a cystatin is 3.2. And I think I'm going to start dialyzing her as well because she's not doing well either.
Yeah, thank you, Charles. I actually did look up that patient. I think the creatinine was like 1.3 and the cystatin C was a little over 3 for the patient you're talking about, the one who's on CRT and then woke up after dialysis. So basically this is to show that serum creatinine, especially in critically ill patients or people who's been in the ICU for a long time, is really not a very good marker for GFR. I did actually reach out to the lab manager at the UC Health, and I was wondering if we can get this in-house. So she told me cystatin C, so right now we send it to ARUP. She said the goal is to eventually to get cystatin C assay in-house, and then things are in the process, but right now there's a delay because of supply chain issue. So at this moment, up until 2 days ago when she emailed me, there's no ETA of when this will happen. The goal is for this to eventually happen. We just don't know when because of supply issue. And then, as I said, right, so there is issue with sort of the instrumentation. Only 2 out of the 5 main companies that make chemistry instrument in the US actually makes the instrument that's FDA approved first to run Cystatin C assay. And there's only 2 companies that actually produce or manufacture the reagent to run the Cystatin C assay. So this is kind of the bottleneck right now. Okay. Well, the other thing to eliminate the limitation of more widely Cystatin C usage, it's the cost. You know, in general, Cystatin C assay is more expensive than the creatinine assay. And I found a few sources. So for the Ontario Health Insurance Plan, which this is the direct cost of testing, not the cost to the patient, to run creatinine, serum creatinine is 25 cents. And then to run a Cystatin C assay, it's $3. So it's 12 times more expensive between these 2 tests. At the University of Minnesota, and this is again a direct cost of the testing, the serum creatinine will cost $2.50 to run, whereas Cystatin C costs 10.6. So 4 times more than to run Cystatin C than the creatinine. And at the University of Colorado, this is the cost that we bill to the patient or insurance company. A BNP will cost about $240, a CNP would be $280, and Cystatin C, the one test alone costs $380. And so, I mean, this is a cost we bill. I don't know how much the patient actually have to pay for this Cystatin C, but this is something to keep in mind because there is a cost difference.
Annie, can I just add the VA? It's $4.77 for the Cystatin C and 0.08 cents for creatinine.
Oh my gosh, that's, wow. Okay. That's a huge difference. Well, creatinine,
Yeah, it's huge. And they're still
Sophie,
pushing
0.08 cents or 0.08 or 8 cents?
8 cents, right? You mean
8 cents. So it's yeah. So sorry. Yeah. Yeah, it's 8 cents. Sorry, guys.
but still, it's
Still, it's huge.
Yeah. Anyway, so cost is the thing. I do think the cost will be better because, you know, with all the things, right, the more you use it, the less expensive it gets. So hopefully in the coming years, like the discrepancy between these 2 assays will not be as large as now.
So we've been working directly at the VA with our Dr. Agarwal, who leads the lab, and he's telling us that the VA is trying to lead the charge in terms of instituting Cystatin C. So hopefully that drives down this cost, but essentially they're trying to really, I mean, we get a Cystatin C plus creatinine GFR, as well as a creatinine only GFR, both with race removed. So we can have both of those provided to us. And
Sophie, are you saying like VA as the nationwide system trying to get Cystatin C, or you're talking about the VA here?
Internet or nationally, excuse me.
Oh, that would be great because I feel like, yeah, that's a lot of hospitals. Yeah. And then the other limitation of Cystatin C usage is kind of awareness of like how do we even use that. So this is a study that's look at the clinician perspective on inpatient Cystatin C utilization. That's done on the Mayo Clinic. So this study interviewed 15 clinicians from various disciplines about their experience with inpatient Cystatin C testing. That includes 5 internal medicine, both attendings and residents, 4 ICU critical care attendings and nurse practitioner, 3 pharmacists, 2 ID doctor, and 1 nephrologist. And then based on their interviews, the barriers to use Cystatin C is lack of education about Cystatin C. Some people were not aware of it, and that's kind of the main thing. And then the other thing is absence of sort of institutional protocol or when we should we use it. That was not clear. Then I was curious, you know, what about our system? So this is no way to be very scientific or statistically savvy, but I did reach out to the primary care providers within UC Health at different primary care clinics that I work closely with. I sent out a survey to them, and then 6 people responded to me. I just want to get a sense of how many people at a primary care level actually use Cystatin C in the ambulatory setting. So out of the 6 people who have responded to me, 4 people said they never actually ordered the test. 3 of them are aware of the test. 1 of them never heard of it until I emailed her. And then 2 of the providers who did order Cystatin C in ambulatory setting, they use it rarely. They use it either to confirm diagnosis of CKD in a patient with elevated serum creatinine, and then the PCP was really unsure if the patient truly has CKD or this is just because the patient have a higher muscle mass. And another provider tells me that they use they will do a BNP or CNP first to screen for renal dysfunction, and for those people who have elevated creatinine, then they check a Cystatin C as a confirmatory test. And I did a quick slicer dicer and kind of just figuring out how many Cystatin C have been ordered at this is the Lowry Internal Medicine Clinic, and I look between January 2019 until March of this year, so a 38-month period, there's a total of 47 Cystatin C that was ordered by all the providers at the Lowry Internal Medicine Clinic. And then in the same time period, there's a total of 143 BNP, CNP, or renal function panel ordered. So the frequency of ordering Cystatin C is about the third compared to ordering of these other tests that will have serum creatinine. And I look at our own clinic. So this is the ordering data from our renal clinic and the university between the same time period, January 2019 to March of 2022. Total, there's 161 Cystatin C that were ordered. And it's actually not bad. And then I also look at, how many BNP, CNP, renal function panel that we ordered in the same time period. There's a total of 250. So the ordering of Cystatin C is about close to 2/3 of the time that we order a test that will have serum creatinine. So we talked about a lot of good things about using Cystatin C to estimate GFR, but it does have its limitations. So one is in obese patients, they do tend to have a higher level of Cystatin C, and that's independent of underlying GFR. That's because adipose tissue have a high expression of Cystatin C compared to other cell types. So obese patient may have a higher serum Cystatin C level just because of this. There's also limitation of Cystatin C used in malignancy. So Cystatin C, as I said, is from all nucleated cells. It is upregulated in certain cancers. And then there are some studies I found that they actually use Cystatin C as the prognostic factors in certain types of cancers, including lymphoma, multiple myeloma, breast cancer, and colorectal cancer. Now they found that the Cystatin C level does kind of tend to trend with tumor burden or treatment response. And specifically, Cystatin C is overexpressing myeloma cells, and there's really strong correlation between the Cystatin C level and the tumor burden. They found that Cystatin C level tend to be higher in patients with more advanced multiple myeloma, and then the level actually falls after treatment with bortezomib. And Cystatin C level is also not very accurate when patient who's on corticosteroid. The level tends to increase in the presence of high dose steroid, and then the magnitudes usually increase by 0.2 to 0.4 milligram per deciliter. And there's other study I found that when patients on prednisone, when it's less than 10 milligram a day, it does not seem to impact it, but when they're on higher doses steroid, it does tend to raise the Cystatin C level, and it tends to be a dose response, meaning the higher the steroid dose, the more elevation Cystatin C in its patients. It is also not accurate or in patients with thyroid dysfunction, Cystatin C level tend to decrease in someone with hypothyroidism and increase in someone with hyperthyroidism. I'll just go through this patient. This is my own patient that I have used Cystatin C. Okay, so, and I get referrals like this sometimes, I have this young patient with no risk factors and refer to me because the baseline creatinine has been high, and the PCP want to know what is the cause of this unexplained CKD, right? So I saw this patient actually a few months ago. His baseline creatinine is 1.4, 1.5. Since he's 30, no proteinuria, no hematuria, renal ultrasounds normal. So then,
Gordon,
yes. Sorry, Charles.
sorry, mistake.
Oh, so then the question is, does he have CKD? So then I checked cystatin actually on 2 separate occasions, and his cystatin is within the normal limit at 0.9 to 1. So I happily graduated him from my clinic and told him that he does not have chronic kidney disease. I have another patient, 65-year-old guy with type 1 diabetes and uncontrolled hypertension for over 10 years. His baseline creatinine has been 1.0 to 1.2. He was really referred to me initially for his hypertension, but when I saw him, he was really cachectic and his BMI is only 15, and he has a little bit albuminuria. So I checked a cystatin on him, actually multiple times, and his cystatin ranges somewhere between 1.5 to 1.8. So the question is, what stage of CKD does he have? This is an eGFR based on using creatinine or cystatin or combined. And then when I use combined creatinine cystatin, his GFR is 48 to 61. So I call him to have CKD, grade 3A /A1 stage. And I have another patient. This is a patient who has alcohol cirrhosis, diabetes. He also has a history of osteomyelitis, so he has a right BKA. His baseline creatinine is 1.3 to 1.8. He has a lot of albuminuria. And then because of his cirrhosis and also the fact that he has had a BKA, I checked cystatin because I just felt like his serum creatinine may be maybe overestimating his GFR. And it turns out his cystatin has been about 1 point higher than his serum creatinine. So the question is, what stage of CKD does he have? And personally, I choose to use the eGFR creatinine cystatin based to estimate his GFR. So then he actually falls into CKD's 3B category. When I was putting together this talk, one of the questions I have, which is still not answered, is what if the eGFR based on creatinine cystatin is very different? Then which one is actually accurate? And I can't really find any studies to really guide me. So this is what I decided to use in my clinical practice. I decided to use the combined one. Okay. Oh, and I have another patient who's 30-year-old with congenital muscular dystrophy. His baseline creatinine is 0.2 to 0.3. His cystatin is somewhere between 1.4 to 1.6. And for him, does he have CKD? And what stage of CKD does he have? So for him, because he has congenital muscular dystrophy, I feel like the serum creatinine is not accurate in his case at all. So I decided to use cystatin-based eGFR calculation when I classify his CKD stage, and he has stage 3A. So in summary, cystatin is a small protein that's produced by all the nucleated cells, filtered through the glomerulus, and reabsorbed by the proximal tubule, but it is not secreted in the tubules. And it's also not affected by age, sex, race, muscle mass, or dietary intake. It's more sensitive marker than creatinine in early detection in acute kidney injury in both hospitalized and critical ill patients. And the equation that incorporate creatinine cystatin tend to be more accurate than eGFR equation using either the creatinine or cystatin alone, especially in our elderly population and patient with cirrhosis. So the most recent KDIGO guideline recommend to use a combination of creatinine, cystatin, urinary albumin creatinine ratio when it comes to screening for CKD. But it is not perfect. It is affected by obesity, glucocorticoid use, thyroid dysfunction, malignancy. So for these patients, cystatin actually might not be the best marker to use when it comes to eGFR calculation. These are my references. I really want to thank you, Charles. He gave me this book that he's the editor, Biomarker for Kidney Disease, and in there he has a lot of really good information about cystatin. Okay.
Annie?
Yes.
Can I ask a question? So I have a lot of patients on steroids, and I've always known, obviously, that cystatin C is elevated in those patients. But from what you've told me today, it sounds like that peak is in 2 to 3 days after they get the steroids, but then how long does it last for? So let's say you have someone who you know, give 3 days of a gram of Solumedrol, and then bring them down. How long do you expect that elevation to last for?
So the study is not great, but one of the study I found is it seems like the cystatin tend to sort of, this effect from steroid tend to sort of taper down after 7 days. It's what I saw.
Okay.
Yeah. But I think it may be, for me, if I were to check cystatin in someone with sort of steroid, I will probably trend it to get a sense, right? Because if someone's on stable dose of pred 20 milligram a day for a long time, and if the cystatin has only a transient sort of effect because of the steroid, then it should like trend down at some point after the steroid initiation and then plateau. That's what I think.
Well, I think it's really helpful that you mentioned that at doses less than 10, it's really not negligible. I'm sorry, I'm trying to walk away from Charles, who has his speaker, so that you don't hear me on 2 areas. But I think if you're less than 10, it's really negligible. And that's a lot of the patients that, are just on 5 of prednisone. So it would be very useful in that situation.
Yeah.
So thank you. That was really helpful.
Annie, that was very helpful. I was going to tell you on some of mine that get big discrepancies between the creatinine and cystatin C, especially in the young women who are trying to get pregnant. You can do the glofil, diethylamate clearance at the university and actually get true measures of GFR. And I've done that on several of them. And then it kind of gives me, now I know exactly what they are so I can risk stratify them better.
So I'm just curious, Jessica, do you feel like for those patients, do their eGFR fall closer to the cystatin C base or creatinine base?
The cystatin C.
Okay.
Yeah. But these are not, obviously they're not pregnant since we're not doing the studies in them, but it's just more like they show up to me with CKD. What do I do? I've done this in other people who are like amputees and, the bit, and then their GFRs are widely different based on that. And so I'm like, well, no one will use one or the other. So I'll just do the true glofil and figure it out. And then I say, this is what we go by. Then I only order cystatin C, although you get it with the Chem 7. So you still get creatinine, but I only use the cystatin C going forward.
Got it. That sounds good. Thank you.
There's a fascinating study that's going to come out that I reviewed for people at the VA. They took 1,000 VA inpatients and they found that 5% of the patients were frail. And the difference in GFR when they used cystatin was like 25, was a huge difference, like 50 versus 25, which could remarkably change how one practices at the VA. I was a bit mean because I was really like, I think we need to do measured GFRs. So I asked them, they need to do some measured GFRs because I really want to know what is the true GFR. If the true GFR is 25 less than the GFR based on creatinine on all the VA patients, we're completely wrong with what we're doing at the VA. What do you think, like, Sophie? It's like huge, the difference at the VA.
Well, maybe you should do a study, Charles. You can at least send them over to the university to do glofils and get true GFR, and then you would know. You could do your own quality improvement.
Yeah, I would say comparing creatinine clearance or the two formulas based on creatinine and cystatin C, I agree with Jessica. In my experience, the cystatin C seems to be better. And so I question combining the two formulas, like combining a bad test creatinine with a good test cystatin C doesn't make sense to me.
Thank you. That's really helpful because that's been the ongoing question I keep having is, which one do I go off with? I see what you're saying, Sarah, because you're saying is if the creatinine really is just not accurate, using the combine actually overestimated true eGFR, and then it sent people in the higher class of CKD rather than
Yeah,
baseline.
and that's people who obviously have high muscle mass or obviously low muscle mass, when it just seems like creatinine isn't the right test.
Yeah, I think, I mean, Michelle can comment on this too, like with the creators of the CKD epi and I mean, this has been very controversial when we started doing the race stuff. And if you look at this all across the country, it's been very controversial. And some of these people are holding hard onto creatinine and hard onto this. And it's more the creators of this and their whole life's work on GFR by creatinine. And so I wonder if we're going to see this morph over the next few years to just cystatin C as that kind of let's go. I don't know. What do you think, Michelle? That's what I keep seeing nationally.
Yeah, no, I agree, Jessica. You raised a very good comment, and Annie, that was a wonderful presentation. And I think what Jessica is trying to get to is that creatinine is an institution within nephrology, correct? It's something that we've been trained to use, we've known about, and even when you talk to Mike Shepak, he has had a very hard time to get generalized use of cystatin C around the country, just because of the reasons that Jessica mentioned. And this is why the VA is probably leading the efforts about, I did not know about Sophie's comment, but it's probably because Mike Shepak, I don't know if people know this, but Mike's main appointment is really at the VA in San Francisco, and probably is trying to kind of create some traction and make it generalizable to the whole VA population. So I agree, Jessica. I think creatinine is an institution, and and they're having a hard time, allowing kind of another marker to be really the main marker for measurement of kidney function.
And I just want to mention the other thing. The other thing is about sort of education, because I have a first-year medical student who I precept in my clinic, and during the whole renal physiology block, so I checked cystatin in my clinic. That's where she learned it. And then during the whole renal physiology block, she asked me, she's like, they didn't talk about cystatin at all in any of our lectures. I don't understand why. But
that's not true. I talk about it in the lecture.
She said
she
no.
Didn't listen to it.
Okay. No, thank you. So because she asked me about it, I was like, oh, I don't know. So I thought
it's in their GFR lecture. I mean, it's a really long lecture that I have to cover clearance and all acute kidney injury, and it goes very fast. But there is a cystatin C part.
Yeah, thank you so much, Sophie, because I do think it's important to let the next generation know, because a lot of this is about awareness, right? Like the more people are aware, and the more likely it will be ordered. Okay.
Annie,
I agree, Annie.
Annie, one last.
VA,
okay, never mind.
But both. Okay, Charles first, and then John.
Sorry, I just want to say the VA in San Francisco has a huge grant in to try and get Cystatin C instituted at the VA hospitals, but the grant starts at the very beginning with training the house staff, and they have flyers that they put out, and they have cards. There's a whole program to educate everybody about Cystatin C. So that's what we need to do. If we have to educate the people here and at the VA in Denver, and we can even make flyers about which patients you would do it in, a number that you can call if you're not sure how to interpret it. Go to noon conferences. They're infiltrating into everywhere at the VA in San Francisco to teach people about cystatin.
Okay, John, last comment.
Yeah, thanks. Great talk. So one thing to be aware of, some people, there's a nascent literature on looking at urine cystatin C for proximal tubular injury. It's transported by megalin. And so it's kind of a marker of megalin-mediated endocytosis in the proximal tubule. The literature's been it's been compared to other urine biomarkers, and it's not as good. It's definitely not as sensitive, but it is pretty specific, i.e. the appearance of cystatin C in the urine. There's little that does that aside from proximal tubular injury. And I only bring it up because, there's a lot of fancy urine biomarkers, and obviously some better than others. But, here at the VA, I tried to get, as we're rolling this out more, I I contacted the pathologist to try to see maybe we could pilot it in a couple people, see if we could get it to work in the urine. He gave me the thumbs down. That was about a year ago. So I'm going to keep trying, because I think it's good to try to leverage the existing tools you have, even if they're imperfect. So I'm going to keep looking into that. But just so you're aware, there's some clinical literature, not just like rat stuff. I mean, there's some stuff looking at HIV patients on tenofovir, and it, like I say, it's pretty specific for people who have have a good evidence of proximal tubular injury. It appears in the urine. So pretty specific, but maybe not so sensitive.
Yeah, but the AKI studies were negative with cystatin C in the urine.
Yeah, I think depends on what's the cause of AKI, and again, like I say, maybe not so sensitive, but pretty specific in people who have that phenotype of like a proximal tubular injury that's pretty robust.
All right, thank you guys. I actually have clinic that start at 9, so I need to run, but I really appreciate you guys participating. Oh, happy Doctor's Day. If you're at the university, you can get the free meals today by showing your badge to the cafeteria. Okay, bye-bye.